Welcome to LPN LaunchPad's presentation on respiratory assessment. This presentation covers lung function, assessment techniques, and abnormal findings. Please feel free to note any questions in the comments. The respiratory assessment systematically evaluates lung function, including inspection, palpation, percussion, and auscultation. Its primary goals are to differentiate normal from abnormal respiratory function and identify early signs of respiratory distress. Consider how these techniques apply to clinical practice and patient care. During the assessment of chest symmetry, observe for equal bilateral expansion during respiration. The chest should rise and fall evenly with each breath. Asymmetrical chest expansion may indicate pneumothorax, pleural effusion, or atelectasis. Reflect on the importance of symmetry as an indicator of underlying pathology. Count the respiratory rate for a full minute and record the rate, rhythm, and depth of breathing. The normal adult respiratory rate ranges from 12 to 20 breaths per minute. Tachypnea, a rate greater than 20 breaths per minute, may suggest fever, anxiety, or respiratory distress. In contrast, bradypnea, defined as a rate of less than 12 breaths per minute, may indicate opioid use, head injury, or increased intracranial pressure. Consider how variations in respiratory rate and rhythm guide clinical decisions. Observe accessory muscles such as the neck, intercostal, or abdominal muscles during breathing. These muscles often suggest respiratory distress or obstruction, as in chronic obstructive pulmonary disease and asthma. Reflect on how accessory muscle use is a visual cue for respiratory compromise. Inspect the skin, lips, and nail beds for cyanosis, a bluish tint that indicates hypoxia. Central cyanosis, especially around the mouth and lips, suggests severe oxygen deprivation and requires immediate intervention. Discuss how visual assessments complement objective measurements in respiratory evaluation. Palpate the chest wall for tenderness, masses, or crepitus. Tenderness may indicate rib fractures, inflammation, or infection, while crepitus, a crackling sensation under the skin, may signal air leakage into the subcutaneous tissue, as seen in pneumothorax. Consider the role of palpation in detecting subtle, yet critical abnormalities. In the tactile fremitus assessment, ask the patient to say 99 while palpating the chest with the ulnar aspect of the hand. A typical finding is a faint vibration. Increased tactile fremitus suggests lung consolidation, such as pneumonia, while decreased or absent fremitus may indicate pleural effusion or pneumothorax. Think about how variations in sound transmission correlate with specific pulmonary conditions. Percuss the lung fields from the apices downward while comparing both sides. Normal lung tissue produces a resonant, low-pitched, hollow sound. Dullness on percussion may suggest consolidation from pneumonia or pleural effusion, whereas hyperresonance may indicate hyperinflation associated with emphysema or pneumothorax. Reflect on how percussion findings assist in forming a differential diagnosis. Auscultate the lungs using the stethoscope's diaphragm over the anterior, lateral, and posterior chest. Normal breath sounds include vesicular sounds, soft and low-pitched over most lung areas, bronchovesicular sounds medium-pitched over primary bronchi, and bronchial sounds, loud and high-pitched over the trachea. Consider how these normal findings establish a baseline for identifying abnormalities. When abnormal breath sounds are present, listen for crackles and wheezes. Crackles, also known as rales, are discontinuous sounds heard during inspiration and suggest fluid in the alveoli, as seen in heart failure or pneumonia. Wheezes are high-pitched, musical sounds on expiration, and indicate narrowed airways, as observed in asthma or chronic obstructive pulmonary disease. Reflect on the clinical significance of these sounds. Abnormal breath sounds may also include raunchy and stridor. Raunchy are low-pitched, snoring sounds that are often clear with coughing and suggest the presence of mucus in large airways. Stridor is a high-pitched crowing sound heard on inspiration and indicates upper airway obstruction, which constitutes a medical emergency. Consider how timely identification of these sounds can improve patient outcomes. A pleural friction rub is a grating sound heard during inspiration and expiration. This sound suggests pleural inflammation, and its presence should prompt further investigation. Reflect on how auscultation findings direct further diagnostic testing. In the bronchophony test, ask the patient to say 99 while auscultating the chest. Usually the sound remains muffled. When the sound is clear and loud, lung consolidation is likely present, as in pneumonia or pulmonary edema. Engage with the audience by considering how this simple test provides critical information about lung parenchyma. Instruct the patient to say E while auscultating the chest for the egophony test. Usually, the sound resembles a soft E. An abnormal finding, in which the sound changes to resemble an A, suggests lung consolidation or pleural effusion. Think about how sounds transform and correlate with structural changes in the lungs. During a whispered pectoriloquy, ask the patient to whisper 1, 2, 3. Usually, the whispered sounds remain faint and muffled. Louder and clearer whispered sounds indicate consolidation, such as pneumonia or pulmonary edema. Consider how subtle changes in sound quality enhance clinical assessment. A systematic approach to the respiratory assessment ensures a comprehensive evaluation of lung function. Identifying abnormal breath sounds, percussion differences, and tactile fremitus findings aids in early diagnosis. Key clinical signs help distinguish among conditions such as pneumonia, pleural effusion, and airway obstructions. Reflect on how each assessment component integrates to form a complete clinical picture. Prioritize airway emergencies during NCLEX preparation by recognizing signs such as stridor and absent breath sounds. Understand the correlation between specific breath sounds and underlying diseases. Consider how a solid foundation in these concepts improves clinical practice and exam performance. Recognize patterns in percussion and tactile fremitus findings to support differential diagnosis. Practice NCLEX style questions to reinforce key respiratory assessment concepts. Utilize mnemonics and visualization techniques to retain critical auscultation findings. Reflect on effective study methods that enhance long-term retention. A nurse assesses a patient in respiratory distress. Which lung sound requires immediate intervention? Option A, wheezing in a patient with asthma. Option B, crackles in a patient with pneumonia. Option C, stridor in a child with respiratory distress. Or Option D, raunchy in a patient with bronchitis. Consider the implications of each finding before selecting an answer. The correct answer is option C, stridor in a child with respiratory distress. Stridor indicates upper airway obstruction and requires immediate intervention. This finding underscores the importance of rapid assessment in emergencies. A patient with pneumonia exhibits increased tactile fremitus. Why does lung consolidation increase sound transmission? Option A, pleural effusion. Option B, collapsed alveoli. Option C, lung consolidation increases sound transmission. Or option D, hyperinflation. Reflect on the relationship between lung tissue density and sound conduction. The correct answer is option C. Lung consolidation increases sound transmission. When lung tissue consolidates, fluid accumulation enhances sound transmission, increasing tactile fremitus, bronchophony, egophony, and whispered pectoriloquy. This phenomenon assists in the identification of pneumonia and related conditions. A nurse assesses a patient with chronic obstructive pulmonary disease who experiences increased shortness of breath. The nurse notes diminished breath sounds and hyperresonance. What is the most likely cause? Option A, pleural effusion. Option B, pneumothorax. Option C, pulmonary edema. Or option D, atelectasis. Analyze the auscultatory findings to determine the correct diagnosis. The correct answer is option B, pneumothorax. Pneumothorax occurs when air enters the pleural space, causing lung collapse, hyperresonance, and diminished breath sounds. Other conditions produce different auscultatory findings, underscoring the importance of accurate lung assessment. Hey there, this is Brian. I am the creator of LPN LaunchPad. I want to say thank you for learning with us. In addition to these videos, I've created a series of free adaptive quizzes in ChatGPT. The link to this video's quiz will be listed in the description below. Help me keep this project alive by hitting the like and subscribe buttons.